Welcome to the next installment of the How POCUS Saves Lives campaign. We're excited to bring you another insightful case with a familiar face if you've been following us for some time. I'm joined today by none other than our Dr. Victor Rao, and my name is Andre Rivette, and we're both here speaking to you today from the POCUS Certification Academy. How POCUS Saves Lives is all about creating awareness for the impact that POCUS can have on patient care. In some situations, it can be life-saving. Vic likes to say that there are people all around us every day who would not be here without the timely intervention that POCUS enabled. We're here to collect stories from patients and providers about how POCUS was instrumental for them, and we're sharing those stories with the community. And we've got one here for you today. Hocus Pocus or POCUS? We're here to talk about point of care ultrasound, or also known as POCUS. I'm sure many of you know what that is, but for those of you who are learning or would like to know, POCUS is a powerful diagnostic tool that empowers clinical decision-making. It enables medical professionals to image structures inside the body to get a better understanding of pathology and pathophysiology in real time. I'm excited to hand over the microphone to Dr. Victor Rao as he takes you through an example of a life-saving story from the use of POCUS. Dr. Rao, first of all, can you say hi, and then could you tell us a little bit about this case?
Hi, Andre. Happy to be here and also share the story. And I'm hoping that this experience can help other patients and also some healthcare providers who may encounter a similar situation and maybe end up saving some more lives. So this was a lady who was brought in by her friend to the rural primary care clinic in rural America. And she just had abdominal discomfort, and she didn't give any history of pregnancy or HCG positive, and there was no history of trauma. And the patient stated upon taking history that she's had 3 spontaneous abortions of pregnancy losses in the past, and no living fetus, no living baby. And patient, by the way, just to kind of remind you guys, is the patient was unaware that she was pregnant.
Is it common for somebody to be unaware that they're pregnant, Vic?
Yes. In fact, I've seen a bunch of patients who were totally unaware that they were pregnant, and even as late as 3rd trimester. So which is kind of shocking to other people. It may be shocking some, but some patients are fully aware, but some, I'm not saying everybody's unaware, but I've been saying is that we definitely encounter patients who may be unaware of that. So it's always a good idea to check. We can do ultrasound, or we can do the urine HCG that will give us that status.
And you also mentioned that this patient had lost 3 pregnancies already. That's devastating.
Yeah. So the next slide, Andre, if we go to the next slide, I think we have some more things that we can talk about. But before we do to that, I think we're going to talk about what we found, because remember, it's not just about POCUS. You must look at the patient's history, take a good history, a relevant history, do a physical examination, and then perform a point of care ultrasound examination, because that is the best way to do it, because now we can put it all together. Solve piece of the puzzle. And patient is anxious, no signs of trauma. I close my eyes, actually, I can still remember that patient. And the vitals were within normal limits, just like tachycardia. And then POCUS ultrasound exam is performed. And we were looking at liver, gallbladder pathology, or kidneys, perhaps some hydronephrosis. But that all was not there. Instead, what we found was that the patient was actually 20 weeks pregnant. And no gross fetal anomaly seen, cardiac activity was seen, that means the fetus was alive. And then no evidence of low-lying placenta previa. But we also did notice something interesting, which is that the patient actually had the internal os was open, and we observed funneling with short cervix. So essentially, the patient was about to deliver or have a spontaneous abortion, So yeah,
Wow.
before we go to inside, I need some questions regarding this.
Yeah, just for clarification's sake, what is hydronephrosis and why is it important to check for that?
Yeah, hydronephrosis essentially two words, hydro and nephrosis. The hydro is water, nephrosis means kidney. So if your kidney essentially become bigger and the collecting system becomes dilated, and that happens when there is obstruction to the outflow of urine. So urine coming produced in the kidneys is coming down the tubes into the bladder. So if there's any point there is obstruction, in this case, as a woman, we like that creates we may think about possibly a ureteric calculus, a stone inside the kidney that is rolled down and stuck in the ureter and causing hydronephrosis. But that was not there, so the patient didn't have any had evidence of hydronephrosis.
Okay, that's important. And then you mentioned funneling very briefly. What is funneling and why is that important to understand?
Yeah, funneling is just an observation. We see that the internal nose is opening up. Normally during pregnancy, internal nose should stay closed and open. I think when we see some more slides and images, that will probably make it a little better for everybody to understand clearly what it is. Essentially, the internal nose opens up like that and starts looking almost like a funnel-shaped structure, and the amniotic amniotic fluid kind of comes into that with the amniotic sac. And so that's really what we are seeing. We will see if we observe that. So the slides may be better to better understand this. So
Understood.
just like we talk about habitual abortion or recurrent, because that's really what the case was. I think we want to make this story more informative and educational. So there's a definition for recurrent pregnancy loss, RPL. It has to be three or more consecutive pregnancy losses. So if it's one or two, that's not RPL. You have to have three losses, and before the fetus reaches viability, about 20, 24 weeks is. And then it's not that uncommon. We see it about 1 to 2% of women trying to conceive or get pregnant. A lot of times it's genetic, sometimes anatomical, as in this case, in this particular patient, there was an anatomical problem. She had a short cervix that lead to cervical incompetence, and sometimes endocrine, sometimes you have immunological problems. And surprisingly, 50% of the time, we don't even figure out what really went wrong. And so that's unknown etiology.
So with RPL, it can't be two pregnancies. It has to be three. Um, and if somebody has RPL, it's important that their medical providers be aware of that, right? And the significance of that, and what could be causing that as well, right?
Yes, so that's the intent goal here with this story is if there are some individuals or some providers who have patients like that who had three or more consecutive pregnancies, they need to investigate and see do they have something like an anatomical problem that is causing that, and that obviously we can correct that by procedure. We're going to talk about that later.
Beautiful. Thank you for taking the time to explain this. I feel like I'm learning as we go here.
So because this is very specific, so we need to understand the cervical length, if it is 25 millimeter or less before 24 weeks pregnancy, that would be uh, defined as short cervix. And also important to understand that the shorter the cervix, the higher the risk of preterm labor. Really, that is the problem because the fetus is delivered before they can even breathe. And that's why it's going to be such a big problem. And cervical insufficiency simply is another term that we talk about, is inability of the cervix to retain the pregnancy. So patient is pregnant because the cervix is short, so it is insufficient. It's called cervical insufficiency, and that causes it to open up, and then the fetus kind of slips through. And in the absence of contractions or labor, that is important. And of course, management strategy is going to be, of course, bed rest. You have to put the patient on rest, and progesterone and circlage. So those are the things. Circlage is something that we're going to talk about a little bit more as what happened in this particular case.
So you're saying a short cervix is anything other or anything under 25 millimeters, and
Yes,
that cervical insufficiency is a result of having a short cervix, correct?
exactly. So If the cervix is short, then it will lead to cervical insufficiency. That means short and not competent enough to be able to hold the pregnancy in there after 20, 24 weeks because the flag is short. And so that is also that 25 millimeter or more, or less number is come from transvaginal ultrasound. If we are doing transvaginal. If we are doing transabdominal, I double check the numbers on those. It's about 29 or approximately 3 centimeters for transabdominal approach. So some of us may not have access to vaginal ultrasound, which, by the way, is the gold standard, is recommended. Then we have only transabdominal. Then we just say we'll go with the number 29 millimeter or 30 millimeters.
Is this a common condition for somebody to have cervical insufficiency? And you mentioned that transvaginal ultrasound is probably the best way to diagnose it, but is this a common condition that we see, with the patient population, or is it just it's very determined by the body habitus of the individual and it's patient by patient basis, or are there things that lead to this?
It's quite common. So just to kind of let people know, that's even in this particular patient, the patient had been seen by the practice and had lost 3 pregnancies previously, and unfortunately was never diagnosed, because she probably lost a pregnancy while at home and then came back and or was brought in and then realized, oh, it's a loss of pregnancy. So there was no ultrasound available. So if you don't have ultrasound in the clinic, how are you going to diagnose that? So this is a condition that you got to diagnose with ultrasound because you got to measure the cervix. And then that, is going to give us the idea as to, because without measurement, we can't say anything. And you can diagnose this before, patient gets pregnant, we can't diagnose it then. We have to diagnose it during pregnancy, in around 20 weeks or 24 weeks, So that's really, you can definitely do that a little earlier than that. Some people may want to check that out maybe around 18 weeks, but I think that's really about the time. But if you're not pregnant, you can't determine that you have short cervix.
I see. There's some factors that limit the ability to diagnose that, timing being one and accessibility to POCUS being the other. That makes a lot of sense. Looks like you've got some good images to show to the group here.
Yeah, the images, Andre, are really helpful because, I can talk all day, but now we're going to go over the image. So we have transvaginal. You can see the advantage of the transvaginal, why people recommend transvaginal, actually recommend it, is because we use high frequency transducer elements, and that gives us really good quality images. And look at it. This is where the probe is touching the patient. It's inside the vaginal canal, and the probe footprint is actually touching the cervix. This is the cervix right here, So, and you can see the cervical canal right here a little bit, but you can see this funneling actually. And what is this? This is the fetal head. The fetal part is here. There's another image. You can something similar. You can see the head. You can have other parts as well, but these examples. So you can see this is where the internal os should have been, and so it's opened up. It's become like a funnel, And I have a picture of funnel and also some more details later on. But basically, that's what you're seeing here. The internal os is open. This is external os, and here's external os right here. And look at this. This distance is very short, as I mentioned earlier. It should be more than 25 millimeter, more than not 25, more than 25. So what is this right here is 13 millimeter. It's much less. And this, obviously, this is the distance that we measure, and we can see because the internal is open. So this has actually kind of funneled it like that. And this, if we don't do any corrective action, this probably will lead to loss of pregnancy.
I'm glad you have these images. Now that I'm looking at it, I can see exactly what you've been describing. I think we've got some more images here.
Yes,
more funneling.
Yes, exactly. So these images are not from that patient. And just to kind of let everyone know that the patient, even though the outcome was great, but the patient did not want their images shared and did not want their name disclosed and their location. So we respect that. But we definitely can share the story anonymously for the benefit of others. And here you can see these images actually from obimages.net, and given due credit to them. And basically, look at this. I just put a little graphic over here for a funnel. So that's kind of looking like a funnel right here. And I have another image, a set of images down the road in the other slides, which show when the funneling is not there, when it's normal. See, this is normal. Normally, we see that the internal os is closed and external os. And again, this is the fetal head. There's some parts, fetal parts, but you can see that this one is actually transvaginal. You can see the probe touching the cervix directly. This example, you see that we are doing transabdominally. So we are obviously, when you do transabdominal, we have to make sure the bladder is full. So when to stand the bladder nicely, make the patient drink a lot of water and hold urine. Once the bladder is full, then you can get a clear view of the cervix right here. So, but it's not that accurate. This one here is the vagina canal. So you only measure this distance, internal os to external os. And for transdown approach, as I mentioned earlier again, we take 29 millimeter as the upper limit. When we are doing this, we want to get 25 millimeter or more than 25 millimeter as normal. So in this example, you can see it's not that straight, it's curved like that. Here it's very straight. So this measurement is great. But when you're doing this kind of measurement, when it's not exactly straight, then I would highly recommend it to actually, by experts, to actually measure it like this. So you break it up in two. So you measure from external or internal os to here, and then from here to here in external os. So internal os, external os, and add the two numbers, and that would give you your cervical length.
And if you weren't to do that and to do those two separate measurements, you might be understating the actual length by, a few millimeters, just because it is curved, as you mentioned. That makes a lot of
So if
sense.
you go straight like that, that would not be the true measurement. And there are some tools also available that kind of the caliper kind of and the cursor kind of moves like that. But it is highly recommended to do a straight linear measurements and then add the two. And some cases, in this example, you got lucky. It's just a straight line, and you can simply measure that.
Beautiful. I'm glad you put the image of the funnel on the last picture here. I think it almost looks exactly like that image here in this. And then when we scroll to the ones that we were just looking at, there is no funneling present. And just by the images, I think you've made it very clear.
Yeah.
Thank you for sharing that. Let's see what else we have to share with our audience here.
So images.net had these resources, these images, and I did put a link to it later on, but you can see how clearly this diagrammatic representation showing internal os to external os, and you don't want to measure here. 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 That would be unnecessarily be a wrong measurement. You want to measure where the tips are touching, like this, like this then, and where it's touching. So this line is really what you want to measure. So you only measure from internal os to the external os. Do not include this, do not include the tissue around there, because that would be incorrect measurement.
Makes a lot of sense. So it's at the bottom of those V's, you want to be where the tissues are actually connecting, not the exterior wall of those tissues, correct?
Yeah, touching, because they are separate actually. It's just that they're touching. So I have some more images that show that really clearly, Andre. So we're gonna go.
Oh, yeah.
So this is really that's what, why we talk about transvaginal. The images are worth, a lot, and you can tell clearly, there's no way I could have determined, like seen an image like this in transabdominal approach. So look at the clarity of this. So when you're doing this procedure, another thing I'll tell folks is to make sure that you magnify the image, because you're focusing only on the cervix. I would just make a really large image, zoom in that area. And you see the white line there. Can you all see this white line? So that's really what the two layers of the cervix are touching inside, cervical canal. So when these two touch and this white line is formed, and so you measure from here to here. So make sure you don't measure here. Make sure you don't measure here. That would be wrong. It's only where these lines line ends, starts and ends over here. That's really, so here again, without any arrows to distract you, very clearly showing. So make sure you don't go beyond it because that would be incorrect.
These are some beautiful images. I know you've already mentioned that, but I have to chime in here. This is great.
Excellent.
So
So this patient underwent circulage, and circulage is really a procedure in which when we have a situation like this, we have short cervix or we have some funneling occurring. And this obviously is not really looking like a funnel, but it's but it's the same thing. It may not exactly look like a funnel. But what we do is we actually put a band over here and we approach transvaginally and put a band. And we will put it right where the cervix canal is still closed. So you can see here, this is the one circular suture and there's another one here. And that's the short cervix, but it's still closed. We don't want to put it over here. We want to put it right where it's still closed. And this goes becoming further vaginal canal. And this is great because it will hold the pregnancy and till when it's ready to deliver, so that the OB team is going to determine that and let the patient know and also follow the patient up.
So someone with a cerclage, they would need to be present at the hospital at the time of birth. This isn't something they could do as a home birth or go to a birthing center, correct? I just want to make sure.
Yeah, the ideal recommendation I would say is go back to the same facility. They are aware of it. They have notes and they know exactly where they put the circlage. They have the technical know-how because not what everybody does all the time. So make sure you go to a competent place or the one that put the circlage originally. They are the ones to cut the sutures and remove it and induce induction of labor. I think that is the better thing. Do not try to deliver at home. So patient must be educated that you have circular procedure. Don't try to deliver at home. You just can't. It could cause serious injuries. Yeah.
This has been super informative. Thank you for taking the time to put together these images and to walk, through them with me and explain these things. I think this is extremely educational. I hope the audience is enjoying as well. I believe that they are. I know that many of you are probably sitting on the edge of your seat at this point, waiting to see the end result of this case. We won't make you wait any longer. Without further ado, Dr. Rao, would you mind walking us through, how did this case resolve? What ended up happening with this patient?
Yeah. So this was really by chance because I wasn't even supposed to be there. Ultrasound was not even supposed to be done, and I was training the physicians in rural America. And the way we train the physicians that I like to do is to encourage them to bring the patients because really you are not going to learn too much if you're just looking at normals. We just look at normal patient. So the way we would do it is they bring their patients who have problems or they don't know exactly what's going on. That's where POCUS comes in. So we trained the physician who was really interested in doing OB/GYN ultrasounds, and so this patient was immediately referred to OB/GYN setup and a clinic and a hospital actually, and they quickly did the procedure, and at 39 weeks, they did surplus band removal, and they also then proceeded to deliver. And this patient had a really great outcome. He had a healthy, normal baby born at 39 weeks, and he was doing really well and living in rural America. That's a beautiful thing. That's really comes to what we are trying to talk about in this particular series is how the life of the baby was saved, unknown fetus obviously that time, and then later on progressed to normal development and then delivered right time. And so POCUS does save life. In this particular example, POCUS did save the pregnancy, and because we know that this lady unfortunately has three previous pregnancies with no living fetus or no living baby. And we were able to make the correct diagnosis on time. And we POCUS assistance solving the challenge, clinical challenge, and solve the problem. And we know exactly what needed to be done and POCUS saves lives. And this was not just POCUS at work. as you saw, everybody came together to have a positive outcome. So yes, focus helps, but focus may not help all the way. So all the way from the nurse sending us the patient, and then the physician doing the ultrasound with me, and then calling the OB/GYN who were gracious enough to accept the patient immediately, to the uh, ambulance team who came quickly and escorted and took the patient to the hospital for the procedure. I mean, everybody came together under, and that's the beautiful thing in medicine. Of course, sometimes we get lucky, we as single-handedly can use focus to do things, but in this particular example, and in many examples, you will actually see it's a team effort. Everybody comes together to do it. And at the bottom, I have the a reference. So if you want to see that particular web page where these images are from, you're welcome to do that. I think that would be great. And there's some more education material there as well.
Beautiful. What an amazing result to this case. Not only is the mother here, but the baby is here as well, which I think is amazing. Thank you again for taking the time to walk us through everything here. While here at the POCUS Certification Academy, we're focused on highlighting the impact of POCUS. I think it's also important to highlight and give credit to the other experts that helped guide this patient to a favorable outcome, as you mentioned. This was definitely a team effort. From the ambulance drivers to the OB/GYN team to the delivery team, everyone contributed, and they're here to talk about it as a result. So that's amazing. You may be sitting there asking, how can I contribute to this? How can I help? You can go to pocus.org/stories. We have this landing page built to collect stories, testimonials, and help share some of the testimonials that we've already collected. If your life has been saved or your outcome has been changed by the timely intervention of POCUS, we want to hear about it and we want to share with the community. And you can do that at pocus.org/stories. Closing out here, we would like to encourage everyone in the audience to reach out to us with any questions, comments, or concerns. You can go ahead and send us an email at pocus@intellios.org. Andre Rivette here, Dr. Victor Rao. It was our pleasure to host you for this session of the How POCUS Saves Lives, and we're looking forward to another riveting case sometime here in the near future. Thank you and stay tuned.
Thank you, Hannah.